Good morning, everyone. Hope everyone is doing well. I see a few new faces in the room, so let's start with some introductions. I'm Lauren Jackson. I'm the nurse case manager on this floor.
I'm Bill Terry, the covering physician.
I'm Trish Hendricks. Good morning, a nurse on this floor.
Hi, I'm Tawanda Underdew, the pharmacist.
Good morning, I'm Ray Fernandez from Rehab. I'm a physical therapist.
And Gary Tripp from social work.
Okay, let's get started. We have 20 patients on the unit, are expecting 5 admissions and possibly 7 discharges. Let's go in order. Let's start with Alex Taylor in room number 3. He was admitted to us this morning. His projected discharge is in 2 days. Bill, do you want to give us an overview of Mr. Taylor's situation?
Sure. Mr. Taylor, a new admission, is a 63-year-old male with chronic obstructive pulmonary disease, congestive heart failure, coronary artery disease, and hypertension. He presented to the emergency department last evening with complaints of shortness of breath from the past 2 weeks. He stated it has worsened significantly over the past 4 days. He also reported extreme difficulty breathing while lying down and walking. When examined, he was very short of breath with crackles in both lung bases and 3+ pitting edema in both legs. His chest x-ray showed pulmonary congestion consistent with a CHF exacerbation. In the ED, he was started on 2 liters of oxygen via nasal cannula and given furosemide 20 milligrams IV. He was then admitted to our unit for further management. Trish, how did he do last night?
Overnight, he was restless and short of breath when moving around in bed. His O2 saturation rates dropped to 87%. I increased his O2 to 3 liters and gave him his PRN nebulizer treatment, and he slowly improved. This morning, he's alert, he's oriented with no signs of pain, but on exam, he still has bilateral crackles in both bases of both lungs and 2+ pitting edema in both legs. He put out 350 cc's of urine overnight after his last dose of IV furosemide, but his output has been borderline over the past few hours. I think he might need more IV furosemide. My goal this morning is to get him up and moving around out of bed and ask him about his diet and to see if he's been taking his medication to figure out what could be contributing to his fluid overload.
Those sound like great goals, Trish. So we have him on IV furosemide. I wonder if the dose is high enough or if we might need a different diuresing agent. Tawanda, what meds is Mr. Taylor on at home?
I believe he's supposed to be taking 20 milligrams of furosemide, PO/BID, at home. When he was first admitted, we started him on IV furosemide, 20 milligrams twice a day, which is doubling his home dose with the change from PO to IV. I agree. I don't think that the current dose is adequate for him because he's still experiencing edema and crackles. His potassium and serum creatinine are stable, so we can increase the dose to 40 milligrams BID. I'm thinking we can control the fluid overload today with IV meds and then switch to an oral furosemide tomorrow. This will help us figure out what he'll need for discharge. I'm working to confirm his home medications and doses now, and then I will check also his refill history to assess his medication adherence.
Sounds good. The last time he had similar issues with fluid overload, he was admitted for a few days at a hospital across town. I'll try and find out more about that admission. Bray, has anyone from physical therapy been able to see him yet?
Not yet, Lauren, but the request was received, and we are set to evaluate him this afternoon. Looks like he lives in a 2-story townhouse with several steps to get into the front door. We'll get more information on his living environment, including his goals and challenges, at a later time. Our occupational therapist went to see him this morning, but he'd already left this morning to get an x-ray. So they'll see him later after he returns.
Okay, thanks, Ray. Trish, what else do we know about his home status?
He lives with his wife, and I was able to speak with her. They've been together for over 40 years. She is anxious about his condition, but is very supportive. Last night, she told me they'd been eating out a lot lately, so we need to find out more about his diet. I suspect processed foods and sodium overload may have contributed to this admission.
Could be. Sounds like there are a few areas we still need to get more info about, and we still need to get his fluid status corrected. Can we plan to move toward discharge in the next 2 days?
That sounds like a reasonable goal at this time. Later today, I'd like to get a echocardiogram, and based on that and how he responds to the furosemide, I think we can probably reach that goal.
Okay, I'd like to summarize. He will be evaluated by PT and OT today. Tawanda, our pharmacist, will update us on his meds, correct?
Yes.
Trish, our nurse, will address his teaching needs, especially his diet. And then I think we should arrange for the remote CHF home monitoring program to help prevent another readmission. Gary, as our social worker, can you help us with that?
Sure, Lauren. I'll look into that and check back with the team.
Great. Any questions, anyone? Okay, let's move on to Mrs. Jones in room 4 and review her hospitalization. A month ago, she was admitted to the ICU with a stroke, left-sided weakness, and difficulty swallowing. She was in the ICU with some ventilation issues, and she became septic from pneumonia. She was stabilized and was transferred to us a week ago. A few days ago, she started on IV heparin for a DVT. The plan was to stop the heparin, begin warfarin PO, and get her ready to be transferred to the acute rehab unit. Trish, how's she doing today?
This morning, her BP was 100/57, which is pretty low for her. She's due for lisinopril soon. Do you think we should hold it? Her heart rate is in the 80s. Neurologically, she still has left-sided weakness, 3 out of 5 in the upper and lower extremities, and on the right side is a 5 out of 5. She's tolerating pureed foods. Her heparin drip is at 800 units per hour, but there are no orders yet for warfarin.
We plan to write for warfarin tonight and discontinue that heparin, but I agree with you, Trish. I'm very concerned that this is the lowest her BP's been in the last 2 days. Let's hold the lisinopril for now, and let me know later on today how she's doing with her blood pressure. We may need to adjust her meds. Tawanda, didn't we adjust the lisinopril dose recently?
Yes, we increased the dose to 20 milligrams from 10 milligrams daily. In addition, she's also on hydrochlorothiazide, 25 milligrams, and amlodipine, 10 milligrams. With the recent stroke, the ACE inhibitor is indicated. Let's consider holding the amlodipine. Also, since her kidney function is adequate and she's having trouble getting around, I think we should consider apixaban instead of warfarin. I can check and make sure it's covered by her insurance, and it would be easier for her since there's less lab draws and we're using standard dosing.
Might be a good idea. Let's think about that. We need to see her coagulation values. Does anyone know her PTT?
Okay, we need to follow up on that. What else do we need to do to get her ready to transfer to rehab?
Well, she is only eating small amounts of pureed food. Speech is evaluating her dysphagia. I'm not sure why she's not eating more. She is motivated to move to acute rehab. Also, we have to wait for the swallowing study results before we can advance her diet. Has anyone seen or heard those?
Our speech-language therapist could not join us this morning, but he is still seeing her daily and will continue to do so until her dysphagia is resolved and she can be transitioned to a regular diet. The swallow study results should be in her chart.
Yeah, those results are still pending. I'll follow up on that. Her nutrition is an important issue, especially for her rehab readiness.
Bill, from a PT standpoint, we've been following her since she came in, and she is progressing slowly. I think she can tolerate the 3 hours of therapy a day. I believe that she's been improving consistently, and I think she'll continue to do so when she's transferred to the rehab unit.
Well, I confirmed that her insurance will cover a short stay in rehab, and I've talked with her and her family about the potential rehab options. She is requesting to go to our acute rehab facility rather than an outside facility. I'll talk with her further and work on the details as long as you're absolutely sure she can tolerate 3 hours of daily active PT.
Yes.
Okay then, to summarize, let's go with Tawanda's suggestion that we get her off that IV heparin and switch her to apixaban, and also evaluate her BP meds. We need to encourage her to build up her nutrition, and we need to monitor that closely.
Sounds like a plan. If no one else has any input about her, let's move on to the next patient.
Sorry all, I just got a text that I need to attend to. I'll check back with you later, Lauren, on the other patients we need to talk about. Have a nice day, everyone.
Great. I'll talk with you later today. Thank you, Gary. Next up is Mr. Washington. How's he doing?
Do you mind if I go first with this patient? I have to go to a team huddle. Yesterday he declined to see us because he said he felt too weak, but we scheduled again to see him this afternoon. Hopefully he'll be feeling up to it. I'll let you know how he does. Thanks. Sorry, everyone. I've got to run.
Thanks,
Thank you,
Ray, could you wait just a minute? We need your input about Mr. Washington. Last night, he lost his balance, which he said was due to hurrying to the bathroom to urinate. Now, he didn't fall, but it was close. We've asked him to call us if he needs to get up, and I've ordered a walker, but I'm worried about him. He thinks he'll be okay. He says he just had to go in a hurry.
Oh, I'm glad he didn't fall. We'll definitely check that out. I wonder if he uses a cane at home. I will make his assessment a priority today. Okay, this is important. I can stay through the rest of the discussion.
Okay, thanks, Ray. Well, I'll begin with an overview of Mr. Lester Washington. He's an 80-year-old African-American male with a history of type 2 diabetes for the past 15 years and hypertension for the last 25 years. This is his third admission for hyperglycemia this year, and this time his glucose was 850. He was confused, lethargic, and hypotensive when admitted. He received fluids and IV insulin on admission to the ED. And Trish, has his glucose been stable?
Yes, this morning his glucose was 112. His vital signs have been stable, and Mr. Washington says that he's feeling much better. His appetite is good, and he says he's ready to go home. He said he ran out of his sugar pills, which he ordered, but they sent him something else. He was confused when he was telling me this story. It seems that some of his pills he gets through the mail, and others he orders through the pharmacy.
We definitely need to look into that. Be sure to assess his safety before he goes home.
Mr. Washington sounds like a great candidate for our Hopkins Home Care Visiting Program. When I met with him earlier today, he was definitely confused about what meds he takes and when he takes them. But he assured me that his wife helps him out with everything. I was hoping to talk to her later today when she comes in.
Yes, hopefully we can sort these things out soon. I was hoping he'd be ready for discharge tomorrow.
Let me just remind everyone that this is his third admission for the same diagnosis in the last year. I think we should take a closer look. Good suggestion with the home care. Bill, can you write an order for the home care? I'll do the referral for our home visiting program, but I think sending him out tomorrow is probably a bit too early, given the need for evaluation and teaching about his medications and making all the arrangements for home. Does everyone agree?
Yes, I agree. Tomorrow might be too soon. He needs help selecting the right foods for his meals, as well as teaching about his medications and recognizing the signs of hyper and hypoglycemia. When I was helping him order foods from the lunch menu today, he went for the wrong mix of carbs and proteins, and he says he always eats that way at home.
Okay, then I will call the diabetes educator and maybe a dietitian. We've got a little more work to do before we can send him home. Okay, up next is Ben Hawthorne in room 12.